right. So good morning and thank you for joining us for this policy committee meeting. I am Amelia Boyd and I am the program manager for the Medical Commission. This meeting is being recorded. The documents which will be discussed here today are available on the policy meetings page on our website, which is wmc.wa.gov. Christine Blake is the chair for the policy committee and Dr. Pam Kohlmeyer is the presenter for these meetings. Once a presentation is finished, Ms. Blake will open the floor for committee and public comment or public discussion. Attendees, if you would like to ask a question or speak, please use the raise your hand function or the chat. Members of the public, when commenting, we request you avoid commenting on ongoing investigations or disciplinary cases. Please make sure your comments pertain to the agenda items. Are there any questions? With that, I will hand it over to Ms. Blake.
Good morning and thank you for joining this morning. We have a few policies that we have to go over with you today. Do you have our agenda up, Amelia, so we can?
I am working on it.
I don't. Thank you.
I'm working with one screen, so.
Oh, okay, got it. So we will start with the guidance document for medical records, documentation, access, retention, storage, disposal, and closing of practice. And I will turn that over to Dr. Kohlmeyer.
Thanks, Chris. So just as a reminder, I'm new in my role, and I'm here to support the work of the policy committee and of our fearless chair, Chris Blake. And this first document is one that went through the commission's brand new 3-step process that involved policies. And that is, first, we present it at an interested parties meeting. Why do we do that? To get stakeholder input. Which is great because it goes along with one of the core values of the commission, which is transparency with the public. And then step 2 is like today. And so this policy was presented at the interested parties meeting 3 weeks ago, and now it's here today to talk about some of the feedback that we got and to open it up for discussion altogether. And then step 3, just for people that are watching, that would be whatever we recommend goes to the business meeting for the full commission. That's when a vote actually happens. Are there any questions about the procedure? Probably not. So this first one is the medical records guidance document. And this item is number GUI 2020-01. And it's basically up for its 4-year review. And this guidance document, we did get some feedback at that interested parties meeting, which I kept as highlights just to alert your attention to it, because I do think it is important that we address comments that we get. The ones in blue are comments that were made from the Washington Medical Commission. I'm sorry, the Washington State Medical Association, WSMA. And so working with them, I like this language. Like, I think it got better with that input, but I highlighted it just so you could be aware. And what started this revisit of the medical records policy at this meeting, because it was already talked about at the one in January, which some of us might have missed that meeting because it was right after the holidays. But we did have a meeting on January 4th, and we talked briefly about this document, and we got some very last minute good suggestions from a patient safety group. And the commission decided at that meeting, the policy committee members decided, let's table this until today so that we can integrate those comments. So those are highlighted in green so that you can be aware of those. And then the other revisions are really to add clarity, to try to make it a cleaner document. And the highlights in yellow are just to alert you to, if you like this idea, those comments were already in the document, but they were buried. I say buried, but they were in a section about closing a practice, but it addresses when a physician's being disciplined or under discipline, they still have a duty to medical records stewardship. And a lot of people under discipline don't close their practices. They are restricted from certain patients they can't see or whatever. And so this way it's more obvious. So with that, I will say too, because there were a lot of recommended changes altogether, there's I say red line version, but it's really blue lines, I guess. The unclean version. And then I also added one that kind of accepts the track changes so that you can actually read it and see the meaning behind the document. And I will say, it already started off as an amazing document before I started with the commission. And this is just trying to polish it up 4 years later with more knowledge about EHRs and medical records. And also, well, I will say too, I did update some of the references to make them current to today. Any questions, or it's open for discussion, I guess, Chris?
It is. Thank you, Dr. Kohlmeyer, and thank you for presenting this as well. This is much cleaner for the folks here to see. Looks like we have a hand up.
Hillary?
Oh, hi. So good morning. Hillary Norris, policy analyst at the WSMA. Just providing comment for the public record, and just wanted to say that the WSMA really appreciates the Washington Medical Commission's willingness to collaborate on draft language updates. And we appreciate you incorporating our feedback into the revised documents. So thank you.
Thanks, Hillary.
Are there any other questions or comments? Concerns? I hear none. So may we approve this document as presented with the changes as noted and discussed by Dr. Kohlmeyer?
I so move.
Second.
All in favor? No, anyone not in favor, I guess I should say.
Great
Okay,
work.
thank you. Thank you. The document is accepted as noted with changes as noted. Our next document is compensation and reimbursement for commission duties. This has to do with the commissioners who take on their role and their compensation for that. And I will turn this over again to Dr. Kohlmeyer. Thank you.
Thanks, Chris. This item is up for its second 4-year review, and it was initially adopted in 2016, reaffirmed in February 2020. There are some minor editing suggestions to add some clarity on our current process, which includes deadlines. So I learned that, it's recommended that commissioners submit things within 30 days, but there's a 90-day hard stop. Otherwise, you'll be denied. So that's always good to know. And then also, too, I added reference to a statute that talks about if we have a commissioner who's a full-time government employee, they're not eligible for compensation. They are eligible for reimbursement. So just to add clarity. The procedure talks about some no-nos, like not using third-party hotel vendors, that kind of thing. And the timeliness is the important part, I think. So using our new process, this procedure was presented at the March interested parties meeting as step 1. There was no input voiced that I heard at that meeting, but recently there was a suggestion that this procedure might be unnecessary as it's all specified by statute, and it could potentially be rescinded and put into an onboarding packet for commissioners when they start. And I heard one other opinion that it is helpful for commissioners to have it laid out so that they understand do's and don'ts, and the statute's kind of laid out for them. So with that, I would say it's open for discussion. Discussion would be good to know if you want it to stay as a procedure or not.
Thank you, Dr. Kohlmeyer. Any comments from the commission side? Amelia has her hand up.
I do. So, Pam and I did talk about this particular one. We only see it every 4 years when it's up for review. So it's not like in front of the commissioners as consistently as it needs to be. My suggestion was to make it sort of an informational document instead of a procedure. Micah does have a recurring blurb about travel reimbursement and payroll reimbursement in his staff report at every business meeting, but you're only seeing that 4 times a year now. So what if we switched it over to an informational document, it can be included in every packet that a commissioner would see. So you get like a little packet for case dispo meetings because there's agenda attached to that. And then you get the business meeting packet. And then it can also live on the website if you want it to. But I think one of the big issues with this particular set of information is that it's not in front of the commissioners enough.
Thank you, Amelia. I, as a commissioner, agree with that. It's not in front of our faces enough. Mr. Lopez.
Yes, I'd like to second what Ms. Boyd has said. I think it's important that it become an informational document for not just the commissioners in general, but certainly those commissioners who are new to know what the expectations are. So I'd like to support that idea.
Are you supporting the idea that it become part of the packet for? Okay.
Yes.
Thank you.
Does it require a motion?
No,
Okay. All right.
I think we have another hand up.
Dr. Lyle and then
Dr.
Micah.
Yeah, thank you.
I would support whatever will put it in front of us more often. I actually learned something by reading this, reviewing this in preparation for this meeting. So I think the more, I mean, it may have been there at the beginning, but there's so much information coming that it's really hard to sort. So whatever format it takes just to get it in front of the commissioners more often, I think would be appreciated.
Thank you, Dr. Lyle. Micah.
The suggestion I would have is also, in addition to the packet piece, you all have a travel folder in your confidential shared drive where you do your casework, and we could certainly make sure to drop this in there so you always have it as an access reference.
Great idea. Go ahead, Pam.
I just want to ask, do you want both? Do you want a procedure and to have it in the packet and accessible, like Micah said? Or do you don't want to have a procedure anymore and only have it in those materials? Either's fine. Just curious what you want.
Thank you for clarifying that, Dr. Kohlmeyer.
And if you choose the procedure, you need to vote on it today. And then if you choose not to have the procedure, you need to vote on that as well. We will still put it in the documents and in the folders that we talked about, but it'll be revised and it'll be more informational than anything else.
As one possible compromise, I'm just thinking of, this is currently one of our procedures. And I've heard people say it's good to have it in front of us as much as possible. If we did adopt this with the amendments for now, add it to the onboarding stuff and work on all procedures, which ones should stay procedures, which ones maybe should be absorbed in other ways. But right now the wording in this is better than it currently is. And it would serve the purpose Dr. Lyle says of putting it in front of us more often, because every commissioner at the meeting on the 26th should read it when it's in the packet. So just as one compromise potential.
Any comments? Thoughts? Dr. Lyle?
So, Dr. Kohlmeyer, you're saying leave it as a procedure for the moment, and then at some further point, you're going to look at all the procedures, and then maybe at that time we'd pull it out if it was deemed. Because I don't understand I don't appreciate the difference between having an informational document versus a procedural document, what that inherently means for the organization. So maybe if that was more clear, but if that was to be addressed later, that's fine too.
Mr. Lopez, you had your hand up and then put it down. No.
That was my question.
Okay.
It was.
Mr. Matthews.
Sure, just to some degree address Dr. Lyle's question. What we're looking at as far as procedures go it's basically good governance policy. So you think of yourselves as a board of directors, and so you are looking at the overall structure of the commission and how you take actions and official votes, rules, discipline, licensing, that kind of thing. A lot of what these procedures entail are operational staff directive things, which in good governance processes is kind of a no-no. So that's one aspect. The other aspect is when I went and reviewed most of the procedures we have, they're not accurate. They're not what we're doing, and that's just simply because the process of bringing them through policy, they get adopted. It's hard to update them, and through the help of Melanie and Anjali and Jimmy, we're a very lean, nimble organization. And so when we identify, much like the Toyota model, when we identify a problem or an inefficiency in the process, we immediately drop what we're doing, we process map it, and we figure out the right way to do it. And if we have to bring multiple units together, we do that. That's a very reactive organization. That's a positive that you want to have within an organization, and not to trash other government organizations, but it's not all that common in government, frankly. And so we have that benefit. So by sending procedures through policy, having them voted on by the commission, and especially the ones that I'm looking at are more operational. And when I say operational, I mean they're directing staff in what Eiler's entries to make. That's very detailed, granular, and operational, and should not be part of commissioner decision making. And so that's really what we're looking at, is how do we, number one, make sure that our processes are efficient and able to be adapted to whatever the organization needs, but also there's a transparency piece that you all are discussing now, which there is a plan to deal with that, and so, but I would like to talk to Dr. Kohlmeyer and Ms. Blake first to help them understand what the plan is to keep that transparency, but also keep the organization nimble.
Can I have a motion for this document?
I'll move. I didn't raise my hand, but
You went on back on mute, Dr. Lau.
sorry. I will move for the compromise Dr. Kohlmeyer suggested of leaving this a policy for the moment and then coming back to it in the holistic way that Mr. Matthews is talking about for future. But as is.
I'd like to second that.
Any other comments or questions?
One clarification, by as is, you mean with all of the new updates, correct? Yeah, okay.
Hearing none, is there anyone not in favor of moving forward with this document and the motion as presented? Hearing none, so moved. Thank you. Our next document is processing complaints against medical students, residents, and fellows. I know this took a lot of discussion and review, and I will turn it over to Dr. Kohlmeyer.
So we have officially opened Pandora's box on this. So today it's on the agenda for two reasons. Number one, we're using our process. This was at the interested parties meeting for step one. So we're bringing it to you today. That's part of our process. Number two, to figure out what the heck we want to do with this, because there's a vast array of thought behind how protective to be with people during their training versus that balance. You know, I like to think of like the balance scale in law, being fair, but if you unnecessarily put the public at risk, that's not okay, because that's our primary focus, is protecting the public. Hello, Dr. Domino. And so this document is up for review. And when we presented it at the interested parties meeting in that process, I was there very thankful that Dr. Bundy from WPHP weighed in to add about what if there's an impaired or a potentially impaired, you know, like a resident. Because I think I was really I've racked my brain about this, about the right way to go, which is your decision to make, not mine. I will say, I think the flavor of this as it is now, without any of the suggested edits or considerations, is a thought about standard of care and negligence violations, period. I don't think it's so much of what about the impaired physician that's showing up drunk to clinic, that it's someone who's taken Demerol out of the Pyxis, that it's someone with a boundary violation, like a sexual misconduct. I don't think the public would care if it's a resident or a fellow or someone practicing for 30 years. If they're groping them, that's not okay. And so really trying to find the right way to handle this, knowing there's not a perfect way to do it. And I will say too, I always think getting more information is good. And so I brought this up at the FSMB has this attorneys group that I got invited to join. And so I just put it out there. What do you guys do? And the only responses I got were, we treat them like everybody else. And our procedure is very protective. And the feedback I got, which wasn't a lot, but it was, we treat them like everybody else to protect the public. So it made me think, I think we need to take a hard look at this. I don't want to vote on this today in any way, but I want to get a direction from you as to where do you think this should be. And I'll point out one thing. There was a meeting between Mike Farrell, who's amazing, like a walking encyclopedia of law and medicine, and him, Frida Pace, the director of investigations, Chris Waterman, like the guru of redactions and all that stuff for CMT. We met and we were trying to figure out, so what are unintended consequences of our current procedure, which is if we have a medical student, a resident, a fellow with, say, some kind of a complaint, it could be whatever, they become a medical unknown in our system. So there's not a record of them having these complaints, with the thought of, if you're in training, you develop this track record that might make it hard to get licensed. It might be hard to get a job. Have you ever been investigated? Yes, I have. You know, back when I was an intern, when I didn't know better. And that's tough. Well, on the flip side, though, if there's no record, then you don't know when someone's maybe a fellow who's done with their residency. Now they're in their second year of their fellowship, and they've actually had 7 complaints about various things. And usually with, I mean, you guys said on CMT, I don't, but knowing if someone's like a repeat offender is often helpful. And so that's the unintended consequence of our current procedure. So I'm just throwing it out there for discussion. I'll write up whatever you want me to do for you to review at our next, you know, take it back to interested parties to get feedback. WSMA, let them weigh in, patient advocacy groups, individual patients, and kind of go through the whole process again.
Are you ready for discussion now, Dr. Kohlmeyer?
Yes.
Thank you. Dr. Domino has her hand up.
Yeah, sorry, I had trouble. I couldn't hear anything and had to reapply before. As someone who's devoted their life to the training of medical students and residents, I feel they should be treated differently. They are in training. The ultimate responsibility is the attending physician, and these are for medical error cases. I agree that if there's some other kind of sexual abuse, some other substance use disorders, those sort of things, those are different. But, yes, they do work independently, but they're in training and people make errors, right? This is the whole thing in medical school is you make errors, and not necessarily medical school, but as in training and as a junior attending. And I feel that the role of the attending physician is to help minimize and prevent those errors from occurring. I can tell you at the university that I have been in lawsuits related to resident care. I shared a portion of the lawsuit because I am the supervising physician, even if it's, say, I had a case that resulted from an IV that was infiltrated, placed by the resident in the case. And then she didn't recognize why it wasn't working, which is it was infiltrated, and then took a pressure bag, fused 800 cc's of saline into it. And then this individual who was a model, a teenager, needed multiple, had multiple scars because she had a 3/4 compartment syndromes that needed to be dealt with. But the fact is, yes, I didn't do it. I wasn't there. I was in another room doing other things. So actually, frankly, another 2 rooms because I worked at Harborview, but that was my responsibility, and I felt that I needed to share and take a large portion of that anesthesia related lawsuit. And that's I really feel strongly about that.
Any other comments? Dr. Domino, do you still have a?
No, I'm trying to lower the hand.
Oh, okay.
It says keep
Anybody?
it raised, and I said no, I don't want it raised. Yeah.
Mr. Lopez?
Yes, I certainly share Dr. Domino's certain concerns and philosophy. I would agree this is a Pandora's box, and the unintended consequences are varied and probably many. But on the other hand, I think certainly that what should be considered is the question of students and or residents when they an event happens that may be a medical error, let's say, as Dr. Domino has pointed out. I think there's a difference between medical error, procedural errors, and moral turpitude. And I think that those 2 issues need to be separated in some way or categorized so that we don't consider them to be equal in magnitude before the community or before patients or before the citizens of Washington. I think our job is to protect the public. And, and I would totally agree, we were all students and residents at one point. And so we were learning, and I understand the concept of learning. But when we have a medical student and or resident who has a moral character flaw, I don't think they are equal to a whether or not they're capable of starting an IV or it's equal to knowing how to cast a limb. I don't think they're equal. And so because of that, I think that there should be a consideration that we should at least consider that there are different levels of behavior and or error that we need to consider something different on how to be able to work with our students and residents. I'm not sure that it'll be perfect, but certainly I think the community would want us to look at this in a way that still protects the public, irregardless of who they may be in the world of medicine. And when I looked and read about this a little more, I thought, well, maybe is it akin to teenagers behaving badly prior to the age of 18, and then when they become adults, then their their record prior to the age of 18, gets expunged. They don't, they're not guilty of anything before the age of 18 because they were teenagers. And I wonder, is this the mindset that we're beginning to consider, that maybe, when you're a resident or when you're an intern, that, you get a pass. And I'm not sure that the public will appreciate that.
Thank you, Mr. Lopez. Hillary Norris has had her hand up for a bit. Hillary.
Hey, so Hillary Norris with the Washington State Medical Association. Just wanted to comment first to clarify, we did bring at the draft document to some physicians in the educational setting to get their feedback. I don't know if now is the time to offer that, though, if it's going to go back to interested parties. So I just wanted to clarify that.
If you want to give a basic, like a 1 or 2 sentence thing, just so that I know where you're going with it, that'd be great.
Sure.
'Cause then the
Yeah.
commissioners would know, and then we can go offline and work through it.
Great. So thank you. So we appreciate the opportunity to review. Again, just brought the draft document to some physicians in the educational setting, and they largely supported what was drafted and just had a few minor changes. One was taking generally out of the sentence due to the established supervisory roles within training programs. A program director is generally in a better position than the commission to manage concerns involving one of their residents or fellows. So just striking generally was a comment from one physician. And then the other was a concern about the update saying that medical students are in the early stages of practicing medicine, specifically the phrase practicing medicine, just because that physician raised that medical students are still learners and don't have a limited license even yet to practice medicine in the same way a resident does. So those were the 2 changes, and we're happy to provide them in writing if helpful. So thank you.
Thank you,
Thank you.
Hillary. I appreciate that. Can I say something too in full transparency? I've had
Oh,
so many
yes.
versions of this trying to update wording and come up with some happy spot. And the version that I gave to Amelia in a crunch wasn't the very initial one with all of the changes. The first one, and I'll apologize for this, the document has a label of medical students, residents, and fellows. And it addressed fellows basically the same as residents. And in an early version, I took out fellows, not like wanting it to disappear, but just thinking, well, these are people that generally have a full license, even though they're fellows. Most of them want to moonlight. And so why is it that we're shielding them in such a way? Understanding, yeah, it's different being like an interventional cardiology fellow if it's a standard of care on doing an intervention as opposed to like inappropriately touching a patient, So that part, full transparency, it currently has fellows in there too. And that led to a discussion of, okay, so our laws for licensing are once you finish 2 years of postgraduate training, you can apply for a full license. And most of them do because they want to moonlight while they're in their last year of residency or while they're in their fellowship. And once they get that full license, it comes with the privilege of getting to practice medicine and make money, but it also comes with more of a responsibility too. Like you're the emancipated minor, maybe. I mean, I don't know. I'm losing Ed's analogy there, probably not very well, but you want to be an adult, then you're with the
Yeah.
adult consequences, maybe. So, but offline, we will work through this, but I just want to know where you want to go with it, because there's so many different variations that could work. Thanks, Chris.
Thank you, Dr.
Thank you.
Kohlmeyer. Mr. Matthews, I'm going to let Dr. Trescott go ahead. Thank you. Dr. Trescott?
I'm just wondering if we could, I really think Karen is right on some of this. And I wonder if we wouldn't want to put where we have the commission may choose to investigate the complaint with the licensed supervisor named as the respondent. Just so it names who actually is responsible. I'm just something like that.
Thanks, Dr. Trescott. Mr. Matthews?
Just 2 points of context based off of the comments. The first one is converting a residency license to a full license. I'm appreciative that we're going to take this back to the interested parties, because that's going to give us time to do more research on the actual number. But anecdotally, the estimate is greater than 80% of resident licenses convert to a full license after their 24 months. So what we really are looking at here with respect to residents is a 2-year period of getting treated a little bit differently for standard of care issues if you potentially go through with this. The other thing, with all due respect to Hillary, I've got to push back on the medical student practice of medicine. That's a direct citation of the statute. 1871-030 sub 8 says the practice of medicine in a medical school setting by students. So the law recognizes that they are practicing medicine and therefore would in other circumstances need a license, but that exemption exists so they don't have to have it.
Thank
And
you.
I will say in the most recent draft I've been floating around, it cites that statute in it, trying to clarify that practice of medicine for the medical students. Yeah.
I see a hand up, but I don't see.
It's
Is
Dr.
somebody?
Bundy.
I think it's Dr.
Oh,
Bundy.
Dr. Bundy.
Yeah.
Thank you. Go ahead,
Oh.
Dr. Bundy.
Thank you. Thank you, members of the committee. Thank you, Dr. Kohlmeyer, for your hard work on this. I definitely support the committee's view of Pandora's box. I've heard a lot of terminology being thrown around here, often in juxtaposition in ways that I actually find a little bit concerning. When we say things like moral turpitude superimposed or juxtaposed to substance use disorders, juxtaposed to professional sexual misconduct, these require conceptual analysis and distinction. Especially from my perspective, the issue of how impairment relates to medical error. There's actually a mountain of data that supports that physician health and well-being actually, or lack thereof, contributes to medical error. So I think that, we don't want to lump certain things together. Health-related problems are different than moral or character defect problems, which are also different from competence, but there is sometimes overlap, and certainly impairment can affect competence. And so I think impairment is, I would argue is fair game for consideration in a policy like this, whereas I would think other sources of problem or discipline might be excluded from a policy of this nature. So those are just some comments that I hope the policy committee will take back as they start to think about how to define these different areas of disciplinary interest. Thank you.
Thank you, Dr. Bundy. Dr. Domino?
Yeah, I agree with Dr. Bundy. One thing when he was mentioning competence, I mean, as well as some, behavioral personality traits and behaviors of residents are evaluated continuously by the residency program. All of our residency programs have dismissed residents due to incompetence. For instance, not immediately early on, but if they're still incompetent, they don't graduate from your program. They still get a license, but they may not be a specialist in that. And I think the role for residents is the role of their residency programs to deal with medical error, as well as their institutions. because they're the ones who, if it goes on to a lawsuit, are paying for them. And again, I agree that other type of things are very different from medical error, even though, yes, if you're impaired, you make more errors. If you're unhappy and emotionally distressed, you have more errors. But there's also a training level, and those of us, we train people over time and give them more independence. And I just feel it's the role of residency program.
Thank you, Dr. Domino. Are there any other comments? I just want to add that the goal here, of course, is patient safety. That is what we're here for, and that's what we're trying to do, and in the best way that we can to assure that throughout a provider's career. And if we treat all the same, then we do not take on every case. Just as an aside, some do not move forward, some do. So if we're treating the same, that would be the same. So that's my comment.
So patient
And
safety is improved by, as Claire said, it's by the attending physician having things go against them.
if there are no other comments, then we will send this back to the interested parties group and move on our agenda. Okay, our next document, proposed procedure for approving accrediting entities to accredit or certify the use of anesthesia in office-based surgical settings. Looks like Amelia's name is on this one.
Correct.
So Amelia, I'm going to turn this over to you.
So some of you have been on the commission long enough to remember the slog of doing the office-based surgery rules, which took like 7 years. Part of that rulemaking is that we used to have a list of approved accrediting entities in rule. And so anytime we needed to add a new one or remove one, we had to do rulemaking. And so when we did rulemaking back in 2017 on this one, we decided to remove the list from rule, and then we are supposed to maintain that list on our website instead. But there has never been a process established for the commissioners to approve those accrediting entities. So I created this one based off of another procedure that you already have in place to approve pain management specialists, I think. Anyway, so my ask here is just to provide feedback on this particular procedure. And then we've had a request to add a new entity to the list. And I'm hoping they get their documentation back to me in time for the next business meeting. But that's all this is a place to have the procedure and then also the list of approved accrediting entities, which is here at the bottom.
Any comments or questions?
I could make one comment. Thanks, Amelia, for doing this. So this didn't make it through the interested parties step one because it came up as a very kind of more last minute, someone wanting to be added to the list. And so we thought, well, because not that it's urgent, but because of the timeliness of it, we wanted to put it before the committee to see what they wanted to do with it.
I thought it looked fine, Amelia. All these things are ones that are all approved, right? So
Right.
I thought it identifies it. So to me, it looked fine.
Do we need a motion on this, Amelia? Do you need approval?
Yeah, recommend approval of the procedure.
Okay, thank you. If there are no other comments or questions, may I have a motion?
Sure. So moved.
Second.
Thank you. Anyone not in favor? Motion carries. Thank you.
Thank you.
Our next document is change to policy committee meeting day or time. Actually, this is more of a conversational piece for us. Based on the fact that it's hard to get quorum, and I know people have, this is taking a chunk out of their mornings, folks that are working, seeing patients. Is this a good time, or would another time be a better fit for those on the committee? And I know not all of us are here, but those that are, what is your opinion? Sorry, Dr. Kohlmeyer, your name was there with that.
You did that better than I could have. Thank you. They'll listen to you. That's good.
I don't know about that, but
Can it be later in the day, like later in the afternoon? That still may impact days, but it doesn't cut out the middle of a day. I mean,
Sure.
I can seldom make these meetings. I just happen to be non-clinical today
sure.
because I worked late last night and I'm working late tomorrow. So it was fine before, we used to meet at 4:00, or wasn't it, at the, when we met in person. So people could make it then. It could even be at 5:00, although staff might have to work later. I don't know. I just think that I was going to suggest early in the morning, but those are, for me, that's often more difficult because I have to be in at work quite early. But also I don't think a lot of people want to have 7 a.m., 6:30 and 7 a.m. meetings. I have a lot of those 6:30 meetings and they're really horrible. So that's why I recommend the afternoon, I think.
Can I make one comment too? Beyond just the people on the committee, it would probably be more convenient for stakeholders too, if it was later in the day. I mean, 10 a.m. on a workday is just tough for most people.
True.
So just with that in mind as well.
Thank you, Dr. Kohlmeyer. That's true. Mr. Lopez?
Yeah, just want to say amen.
Okay.
I echo Dr. Domino's concerns. It's tough to be functional in a administrative or clinical role and then try to make another meeting at 10 a.m. So I think I certainly would advocate for a 4 p.m. or so meeting, when sort of the end of the day, when we can make plans and sweep all that other stuff out of our lives and we focus.
Thank you, Mr. Lopez. Mr. Matthews?
Just two comments. I think one of the reasons that we were able to make 4 p.m. work before is because you had case reviews keeping people that same day, so you were all already gathered. The second thing I have is that we've got a number of stakeholders on the call right now, and it might be good to ask them what would be a good time for them to participate.
Sure. Comments from anyone on this call are appreciated. Is there anyone else that has a preference or a comment?
Dr. Trescott?
I agree.
Okay.
4:00 works better. It's also a Zoom meeting that can avoid traffic for some of us. So I like the 4:00 better.
Thank you.
I don't know if that makes sense, but it makes sense to me.
Thank you, Dr. Trescott. And the folks that aren't here, Mr. Rogers, it may just be that as a practicing attorney, he does not have the time either right now. So should we move our next meeting then to 4 p.m.? I think we can go ahead and do that, Dr. Kohlmeyer.
All right. So that'll be, let's see, I'm looking at my calendar, the 27th of June. Oh my goodness. Summertime.
Yeah.
All right. 4 p.m. Put it on your calendar.
Thank you.
Fabulous. Yep.
And our next document is policy development request for recusal. And I'll turn it over to Dr. Kohlmeyer.
So both of these should be rather quick. I see we have 10 minutes left, and I think we're going to get in just fine, so don't worry. So this first one, my understanding, I wasn't at the meeting, but the fall business meeting, I do believe that our executive director gave a presentation about recusal, about when commissioners have conflicts of interest and keeping fundamental fairness. And the commission was very in favor of coming up with a policy. And so now with the policy committee, we have a policy on policy development, and it says that this committee determines, like how we move forward. So this is just kind of a touch base of how would you like to move forward. As far as like, do you want a work group? Do you want me to draft something initially? How do you want to go about doing it? I'm open to whatever. Possible timeline would be that we could do the drafting now, get it to the interested parties meeting in June, before you for review in June, and vote on it at the commission meeting in July. I think that's doable if that's the way you want to go. Or if we want to do, saddle up the work group, we could still try to meet that timeline. It depends on who wants to have input, like really close input on this as it evolves. Any discussion?
I'm happy with what you propose. I think it needs to get done quickly. I don't see the need for a work group. And I think, isn't that Kyle there, sitting there in your little pit? Yeah. I mean, it is an issue. I think we need that has been affecting us. And so getting it done, having the legal assistance in writing this, I think is then it gets brought back. So then we can provide some input to it, but I need it to get done quickly.
Thanks, Dr. Domino. Anyone else? Mr. Kiernan. Oh, you're on mute.
Technology has not been my friend today. Every time that I try and unmute my laptop so my camera can work, it turns off everything else, all my screens and my mouse, which has made it a super big challenge. It's been a lot of fun this morning. Just for the benefit of the policy committee, Pam, as well as Heather.
You're cutting out.
Kyle, you might need to get closer to your screen.
Okay, how about now? Okay. We've been working in the background on some draft parts of a potential procedure as well as a policy in this regard. So Dr. Domino, we should be, and Ms. Blake, we should be ready to go in June if that's the preference for the committee. We've met a couple different times on this. Pam has kind of a working draft that's pretty far advanced, but I think you guys will need for your discussion. Now, whether or not that actually translates into, yes, this works for everybody, or yes, this is, hits the levels of transparency that we want, is up for debate. But I'd really recommend, and so to the extent that Dr. Domino has already recommendation, that you do this sooner rather than later. Because again, I think once you look at this and look at some of the principles that we're talking about, it's not.
We lost you again.
Oh, I'm sorry. June would be in terms of a recommendation.
So, Mr. Kiernan, we lost you, but are you in favor of this going back then? Is that the? Yeah, I think he's typing. Are there any other comments from anyone else?
I just have one. I just put my direct email in the chat. So if there's any stakeholders that are watching that want to weigh in as I'm drafting this, now would be a great time to reach out. Makes it easier for everybody.
Thank you. Thank you, Dr. Komar. If there are no other comments, then we will be bringing this back in June. Thank you. And our last document for today is Policy Development Request AI. Dr. Kohlmeyer.
Yes, thanks, Chris. So similar, but not quite the same. So this wasn't discussed or like gotten a nod from the commission in the fall, but it has been pointed out that this is such a hot topic in medicine and probably worthy of a policy. And we'd be kind of on the forefront of developing a policy. Micah's been instrumental with trying to keep up with all of the updates in AI and kind of where things should go. And so I can defer to him. It looks like he wants to speak, but trying to do a similar timeline, unless we want a work group to address this, to have it go to interested parties in June, before this committee in June, and voted on in July. Yeah, Micah. Ooh.
Thanks, Pam. So there's a couple of things at play with this. First off, since 2017, you have been the only medical board with any guidance with respect to artificial intelligence use in healthcare. That is at the end of your telehealth or telemedicine and continuity of care policy. However, during this legislative session, the Uniform Telehealth Act was passed in Washington State, which largely mirrors what you have had in policy since roughly 2015. But so that's going to necessitate repealing the telehealth policy in June, which means that not only the duplicative policy that you have had and that has now been superseded by statute would go away, but also that AI regulation piece. So in light of that, in light of the advancements or the development in the AI space with healthcare, and also the fact that next week or the week after, FSMB is going to introduce its ethical principles of AI use in healthcare, which the current draft that has been getting passed between Pam and I cribs heavily. I think would be the word that we would use there from that particular document. That's all coming forward. I think that what I would recommend is have it come forward to the interested parties group, and based off of what comments we get back, if a work group does need to be created, fine. Otherwise, you may like what you see and let that go forward for debate.
Thank you, Mr. Matthews.
And then
Are there any other? Go ahead.
sorry. So real quick, what you're going to vote on today for this is whether you want to initiate the policy, because you're already discussing the timeline and recommendations, and whether you will create a work group. So you're voting to whether you will initiate the policy.
Thanks for that clarification. Hillary has her hand up.
Oh, yes, just really quickly, wanted to state that the WSMA is currently hosting an AI work group focused on this issue, and we would be happy to partner with the Washington Medical Commission on any efforts in this area, sorry, including reviewing any draft language, etc. So thank you.
I think Dr. Lyle has her hand up. Is that who I'm seeing?
Dr. Domino.
Dr. Domino. Okay, the hand is covering the face, so I can't see.
Oh.
Dr. Domino.
Yeah, so it sounds like there's some urgency to get something done, which to me means that we don't need a work group right now. I mean, and I think, thinking about it more, I mean, anyway, that was just my feeling, right? Micah, isn't there urgency from what you say? Something's going away and we need to have something in place.
Yeah, there's a need to repeal the telehealth policies you have now. The bill that passed goes active effectively June 6th. So you would be voting to repeal that June. Well, I think June 27th is what someone said the next policy meeting was. And so we don't want to repeal that too early. So there's a little bit of a timeline lineup issue, but that shouldn't be a problem. And the main reason I'm recommending no work group at this point is the approach that I try and take with policy development, especially in newer areas, is a less is more approach. You just don't want to be overly specific for something that's going to evolve and you can't adequately predict what we're going to see. So we're just basically focusing on the principles of use and then some major guardrails. And so just as a preview, really it focuses on informed consent, both of the patient and the practitioner using it. It focuses on how AI should be considered, i.e. a peer-to-peer concept. And then it also applies what I would call the PA practice concept, whereas the example is if you are let's say a psychiatrist, you can't use AI to help you do dermatology, that kind of thing. So it's a sort of the stay in your lane concept. So that's the broad strokes of what you would see at the interested policies group or interested parties group.
I mean, that sounds good to me. As Micah and I and Kyle attended the AI conference in January, I actually wrote a little blurb about it in my piece in the newsletter whenever that, or if it came out, I didn't see it. But at any rate, it's a work in progress, this whole issue on AI. And I thought sure, you can have a work group to deal with something at a slower process, but just getting something out that Micah recommended to me seems appropriate as we learn more and it has more uses. The one thing I can say, Micah, though, is sometimes people don't know that they have AI being used. Um, I mean, they may for filming and recording office visits that may have one, but if you're using AI to predict outcomes in patients, they may not know that. As an example, or I've worked on a device that they're all research patients, but these devices are used in non-research things. Like an example, at Swedish hospital, I hear they use these devices. They incorporated AI, and a lot of it, of course, in radiology incorporates a huge amount. So that's I don't know. They're all different types of AI is the whole problem. Right. And they're not all the same. But yeah, I like the idea of doing something quick and then forming a work group and working with WSMA on something. And things will change in 6 months.
Thank you, Dr. Domino. Are there any other comments? Dr. Domino, would you like to make a motion to that?
Sure. I move that we do what Micah had suggested and having a brief document on AI to develop very quickly.
May I have a second?
A second.
Thank you. Any opposed? Hearing none, the motion carries. Thank you. And I think that we're at the end of our agenda, just 4 minutes past our adjournment time. So I appreciate all of your attendance. Thank you so much for all your comments and your participation and your dedication to patient safety. The meeting is adjourned.
Thank you, everyone.